Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. For hospitalized patients, generally speaking, it's great news to hear you're being discharged and going home at last. But years of evidence have shown that this transitional period is particularly fraught. Countless factors, from incomplete instructions, lack of continuity in care, and delayed follow-up, can lead to serious setbacks and even harm like falls, infections, or medication errors. These, in turn, can lead some patients right back in the hospital again. Is it possible to reduce the risks associated with such transitions? That's the subject of today's Health Podyssey. I'm here with Dr. MacKenzie L. Hughes, a psychologist and senior research scientist at NORC at the University of Chicago. Together with co-authors, Dr. Hughes conducted a study whose findings are published in the June issue of Health Affairs. Its title is also its main finding. Quote, transitional care management associated with more healthy days at home, lower spending after hospital discharge. And I'm really excited to hear more about the paper, so let's just dig in. Dr. MacKenzie L. Hughes, welcome to the Health Podyssey.
Thank you. Thanks for having me.
So let's start with some background. What do we mean when we talk about transitional care? I alluded to a little bit of that in the introduction. Did I do a good job of describing most people's experience of transitional care? What does that typically involve? Where are people transitioning from and to, and who's involved?
Yeah. Your introduction was a nice overview of kind of what we're talking about here. And this is a good place to start. So, when we're referring to care transitions, we're really talking about this movement that a patient undergoes when they are moving between healthcare providers or between different settings. And this movement typically happens as a patient's healthcare needs change. So in our paper, we refer to care transitions. Kind of what we're really talking about is the transition that a patient would make from the hospital setting to a community setting. And for many people, this would look like, for example, going home from the hospital.
Okay, and traditionally, these transitions have been associated with bad outcomes and high costs. Why is that?
Yeah, so you mentioned a few of those outcomes in your introduction. So, a patient's transition from the hospital to home or to some other community setting can really kind of put them in a vulnerable spot in terms of their risk for rehospitalization and these other kind of poor outcomes. And, as I mentioned earlier, these transitions, during these transitions, a patient might experience changes in their healthcare settings or changes in the individuals that are responsible for their care. So really to successfully coordinate these transitions and to avoid those bad outcomes and to avoid the high costs, information needs to be shared with the patient and with the individuals that are involved in the patient's care. So this can look like, communication between the patient's healthcare providers. That's really critical here. It can also, it's important that patients and their caregivers have the information that they need to manage, the patient's health condition and their medications as they're, going home.
So the scenario I'm envisioning is, someone's in the hospital, they're typically being cared for, or at least their care is overseen by a hospitalist, someone who's sort of managing their in the moment in the hospital care. Then they're sent home and they usually say, follow up with your primary care provider in 2 days or something like that. Is that sort of a typical transition, and is often, I imagine there's some loss typically of information when basically the report goes from the hospital to the primary care provider. Is that fair?
Yes. Yeah. So, maybe the patient has been seeing one doctor, maybe they're a specialist, and now their care will be managed by someone else. Maybe it's their primary care provider. And, what we know and we can dig in a little bit more about these TCM or transitional care management codes is in many cases, it's the primary care provider that's providing the services. So yeah, that scenario that you described, I think, is a good one here.
Against this backdrop, let's say policymakers kind of looked at the situation. They said, this is a problem area. So let's have Medicare reimburse clinicians to manage these transitions. I think this started in 2013. Can you say a little bit about the theory driving that policy change around the reimbursement? Was it simply a case of policymakers saying, well, the reason these transitions go badly is because no one has an incentive to manage them? Or did we know more about what was kind of going on under the hood at that point?
Yeah, there were a few things going on around that time that Medicare had introduced these transitional care management codes. So kind of looking back on what was going on, first, pre-2012, 30-day rehospitalization rates were pretty high, and vulnerable patients were kind of revolving from the hospital to the community and back. And obviously that's not ideal. And so this prompted Medicare to make a couple of policy changes. So first, in the fall of 2012, Medicare introduced the Hospital Readmissions Reduction Program. And that program incentivizes hospitals to pay attention to, how and where they were discharging patients. And then second, just a few months later, so in 2013, Medicare had introduced the transitional care management codes, and those codes are meant to incentivize the practitioners to better care for their patients after discharge. I should mention, before these transitional care management codes were introduced, Medicare did not pay for any kind of face-to-face services that the patients needed during their care transitions, like medication reconciliation, scheduling follow-up visits and referrals, or helping patients access community resources and support services. So, through these TCM codes, Medicare started to pay practitioners, and again, primarily, I think, primary care physicians for their time spent on care coordination, care transition activities that go beyond that office visit. And then, one more thing was going on around that time. So, around the time that Medicare had introduced those TCM codes, they also started implementing alternative payment models, which I'm, of course, happy to talk about in more detail. But, these models were also helping to address better delivery of whole person care while reducing spending. And so our work and the work of others has shown that these alternative payment models adopt TCM or transitional care management as a key strategy for coordinating care during that post-discharge period where, a patient is transitioning from the hospital back to the community.
Gotcha. So what I think you're hinting at is that the ACOs and other alternative payment models have sort of included this transitional care management as sort of like one strategy of a menu of strategies that they're using. And that it's fair to see the transitional care management reimbursement as sort of a piece of this kind of larger vision and not just a standalone fix that someone has said, let's, flip this switch and things will get better.
Sure. Yeah. What we're finding is these accountable care organizations and others that are participating in these alternative payment models are more likely to adopt these care transition, management services.
Great. Well, in just a second, I want to ask you about the findings of your study. But before we do, let's go to a quick break. And we're back. I'm here with Dr. MacKenzie L. Hughes, talking about her paper on transitional care management and its association with increased healthy days at home and lower spending after hospital discharge. I kind of spoiled the end here, but I wanted to ask you about the findings of your paper. I just hinted at them with the title of that paper, but can you tell us a little more about the outcomes that you studied and what you found?
Yes. So our analysis focused on examining the associations of transitional care management and alternative payment models on 4 quality and cost outcomes. So those were readmissions, mortality, healthy days at home, and then total Medicare spending. And specifically during the 31 to 60 day period after the patient was discharged from the hospital. And so before I talk about our main findings, I just quickly want to mention, that we had categorized hospital discharges into kind of in a couple of different ways. First, we had categorized discharges into those that received TCM and those that did not receive TCM. And again, TCM is the transitional care management. So you can kind of think of these as the treatment and comparison groups, And then we also categorized the discharges into those that were aligned with alternative payment models and those that were not aligned with an alternative payment model. And so, really what we were trying to get at here was if you kind of imagine yourself as the patient, if you received TCM services after leaving the hospital and you were aligned with an alternative payment model, are your outcomes better and are your costs lower compared to someone else who also received TCM, but maybe, after leaving the hospital, but they were not aligned with an APM. So I'll share kind of our main findings, which I know are also in our title, but first with the healthy days at home outcome, we found that the association between TCM receipt and healthy days at home was more pronounced in the patients that were aligned with alternative payment models compared to those that were not aligned with an alternative payment model. So, basically if you focus on only the patients that received TCM, the patients that were aligned with the alternative payment model had more healthy days at home compared to those that were not aligned with an APM. If you look, at our results, we are talking about a difference in a fraction of a day during that 31 to 60 day period following hospital discharge. But I think, as a patient who has been ill or has had to undergo treatment in the hospital, having any additional healthy time at home and being out of the hospital is meaningful. So we were excited to see that result. And then in terms of costs, the association between TCM and total Medicare spending was also more pronounced among the patients that were aligned with the alternative payment models. So again, if you focus only on the patients that received TCM, the patients that were aligned with an alternative payment model had lower spending compared to those that were not aligned to an alternative payment model. So those were the 2 main findings, and those findings, were incorporated in the title of our paper.
Great. And what do we know about the socio-demographic factors at play? Were there segments of the population that were more likely to see the benefits of transitional care management, or what other sort of variation did you see that might be illuminating?
Yeah, our findings did show that certain groups of people were less likely to receive transitional care management. So, for example, Black and African American beneficiaries and those who are dually eligible for Medicare and Medicaid were less likely to receive transitional care management. And then we also found that beneficiaries who are female and white were more likely to receive transitional care management. And these findings are consistent with prior research and with the literature showing sociodemographic differences in access to healthcare. And this is a area of future work. I think, we need to better understand the impact of this uneven delivery of TCM services and how it might impact health disparities.
Your data ends in 2020, which, as we know, was sort of the early phases of COVID. And do you have a sense of whether or not the pandemic's impact is manifest in this data, and maybe how the results might have changed if your data extended another additional 2 or 3 years?
Yeah, this is a good question. I'm glad you're bringing this up. And it's an important point to clarify for our paper. So eligible hospital discharges that were included in our analysis were taken from 2018 and 2019 data. And like I mentioned before, our study outcomes were measured between 31 and 60 days following hospital discharge. And I'm saying all this because the latest possible follow-up data included in the analysis would have been from March 1st, 2020, which is still prior to when the COVID-19 pandemic began in the US. So we cut it close, but all of the outcome data included in the analysis were from before the pandemic. But, regarding the second part of your question about how our results may have been different had our data overlapped with the pandemic, of course, the pandemic introduced all kinds of challenges on the healthcare system, and it's hard to know how our results would have been different. But what I will say is TCM is really focused on follow-up care and contacting patients and their caregivers after they leave the hospital. And these follow-ups can actually be made using telehealth, like a telephone call or email. So there's flexibility in how the TCM follow-up contacts are made with patients. And then on top of that, we also know that alternative payment models have been kind of at the forefront of adopting telehealth, supported by Medicare waivers. So kind of considering these details, I'm going to guess that our results may not have been all that different had we done this same analysis using data from a couple years into the pandemic. But, this is sort of my best guess. I think there's, this is a good area of future work, kind of looking at how results might be different if we're using data from, 2020 to 2022, for example.
Okay, let's assume you have maybe a few members of Congress on your email distribution list, and one of them is really interested in their aging constituents. The rising costs associated with the aging U.S. population, their care, the fact that our system seems to be consistently failing them. They read this paper and they come back to you with something along the lines of, what do we do now? So based on the findings of your paper, where would you recommend that a policymaker, whether in the federal level or the state level, go forward in terms of potential policy changes inspired by your findings?
Yeah, so our results indicated that beyond the overall benefits, TCM may be a useful strategy within alternative payment models to help reduce spending while maintaining or improving quality. So there may be complementary effects between TCM and these alternative payment models, or these two policies may be reinforcing. That's really what our results can say. Our study did not focus specifically on identifying areas for practice and policy recommendations within TCM or APMs, but given our results, I'll say a few ideas. So first, practice leaders should consider both strategies, TCM and alternative payment models together in care redesign initiatives. Second, policymakers could consider harmonizing across TCM and alternative payment model policy as Medicare continues to work towards its goal of treating all Medicare beneficiaries through these accountable care relationships. And then third, our findings showed that TCM services may not have been used or delivered for many beneficiaries who may have benefited from them. So again, our findings can't speak to this directly, but given the promising results associated with these transitional care management codes, I think there are efforts that could be made to increase uptake of the services. So for example, policymakers could consider making adjustments to TCM. The current codes only allow one healthcare professional, either a physician or a qualified non-physician practitioner, to bill for TCM services for each beneficiary. And the codes don't really incentivize like a co-ownership of patients across multiple providers, and they don't account for the number of team members that could be involved in delivering the services. So I think, policymakers could consider opportunities to expand the codes to increase adoption by allowing groups of clinicians to receive reimbursement, to promote, team-based care, or expanding the codes to more, so that more non-physicians could provide and receive payment for TCM. And then one other kind of adjustment I think maybe policymakers could consider is figuring out how to reduce some of the administrative burden that is associated with TCM delivery. So there's some evidence showing that, it can be a burden to billing. I think especially billing for TCM codes has been has placed a lot of administrative burden on staff. So, those are just a few ideas that, we have in terms of, what do we do now? What's next for this work? But again, our paper was really focused on understanding how the two policies might be working together.
Great, a great roadmap for potential policy changes going forward. That's a good spot to stop. Thanks so much for joining us here today. Really appreciate it.
Thanks so much for having me.
Absolutely. To our listeners, thanks for tuning in. If you enjoyed this episode, leave a review, recommend it to a friend, and smash that subscribe button. We'll talk to you next week.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about the Health Podyssey.